This is the Transition Series Topics for the EMT, Topic 6, Ambient Air, Airway, and the Mechanics of Ventilation. Our objectives are to understand gas composition in the air and the effects of imbalances on metabolism, to discuss the structure and function of the airway, to discuss determinants of alveolar ventilation, to discuss ventilation and cellular oxygenation, and to discuss adequate and inadequate ventilation. This chapter and the following two chapters introduce pathophysiological principles. The components associated with perfusion must function in unison if an organism is to survive. Perfusion is the constant delivery of oxygen and glucose to the cells and the adequate elimination of carbon dioxide and other waste products. To maintain adequate perfusion, the following components must work properly: the airway, ventilation, oxygenation, and circulation. A disturbance in any of these components could lead to poor perfusion with resultant inadequate delivery of oxygen and glucose to the cells, or an ineffective elimination of carbon dioxide and other waste products. If the disturbance is grave enough, the cells will eventually dysfunction and die. Again, the first three components are ambient air, the airway, and ventilation. The amount of oxygen in the ambient air will determine the concentration of oxygen breathed by the patient, which in turn determines the amount of oxygen reaching the alveoli for gas exchange. A decrease in the concentration of oxygen in ambient air will directly reduce the amount of oxygen available for cell use. Oxygen therapy is designed to increase the concentration of oxygen breathed in by the patient. By doing so, more oxygen is made available in the alveoli for gas exchange, and more oxygen reaches the cellular level. Cellular hypoxia, the deficiency of oxygen reaching the tissues of the body, may be reversed or lessened by increasing the percentage of oxygen the patient breathes. This underscores the importance of oxygen therapy, recognizing that disturbances may lead to oxygen displacement in the atmosphere or disturbances where the body does not use oxygen correctly. The pressure of the gases on our body is measured in millimeters of mercury. Oxygen, which comprises 21% of the air, comprises 159 millimeters of mercury of the pressure against our skin. Nitrogen, which comprises 79% of the air, exerts a pressure of 597 millimeters of mercury, and argon and carbon dioxide and other trace elements comprise another 7.3%, or 7.3 millimeters of mercury. Pardon me. The patency of the airway is one of the most basic and important steps in prehospital medicine. Without an adequate airway, all other interventions are doomed to fail. Obstructions can occur at several anatomical locations, either in the upper or lower airway structures. Obstructions that may occlude the airway include blood, vomitus, other secretions, tissue, bone, teeth, food, and many other substances. In the unconscious supine patient lying on their back, the most common cause of an occluded airway is the relaxation of the muscles controlling the mandible, which allows the tongue to fall back into the pharynx, or the space behind the mouth, and block the air moving into the airway. An airway obstruction, however, can occur at many anatomical levels. Wherever it occurs, it must be corrected immediately. Here's a drawing of the airway. Air enters normally through the nose and passes into the nasopharynx, passing over the turbinates, where the air is warmed and moisturized. It passes through the oropharynx behind the mouth and through the glottis opening into the trachea or windpipe and down into the right and left main stem bronchus, then into the into the bronchioles, and finally into the little air sacs called the alveoli at the terminal point. The alveoli comprise the mass of the lung. The voice box or larynx is where the vocal cords are. It's immediately under the glottis opening. A flap called the epiglottis closes when we swallow to prevent food and liquid from entering the airway. The mechanics of ventilation include inspiratory and expiratory muscle action and the action of the accessory muscles. Changes in intrathoracic pressure create airflow in and out of the lungs. When the diaphragm and external intercostal muscles contract, the size of the thorax or chest increases. By increasing the size of a closed container, the pressure inside decreases, becoming a slight vacuum. The difference in air between the outside air pressure and the decreased pressure inside the chest causes air to enter the lungs through the trachea. It's not a great shift in pressure. At sea level, the total atmospheric pressure on our skin is 760 millimeters of mercury. When the inspiratory muscles contract during inhalation, the intrathoracic pressure drops 2 millimeters of mercury to 758 millimeters. This drop in pressure is sufficient to allow air to be drawn into the lungs, causing inhalation. Factors affecting ventilation include compliance issues and airway resistance issues. Compliance is the force required for the lungs and chest wall to expand, creating a negative space to draw in air. Conditions such as emphysema that cause the lungs to become stiffer make it more difficult for the chest to expand. This is referred to as a decrease in compliance. You may experience poor compliance when you find it more difficult than usual to deliver ventilation using a bag valve mask device. Resistance to airflow through the respiratory tract is determined by any obstructions and by the internal diameter size of the lower airways. Mucus, swelling, and bronchial constriction are the most common causes of obstructed airflow, resulting in higher airway resistance. Higher airway resistance requires the patient to work harder and expend more energy. Patients who are working very hard to breathe may fatigue and eventually enter respiratory distress and failure. Both compliance and higher airway resistance may lead to a decrease in the amount of air reaching the alveoli for gas exchange, resulting in less oxygen reaching the hemoglobin and eventually cellular hypoxia. On the left, we see a normal bronchiole with a normal lumen or internal diameter, plenty of space for air to move. In a constricted bronchiole, as in asthma or bronchiolitis, the bronchiole is swollen, mucus is being produced, and the internal diameter is greatly decreased, raising the resistance to air moving into the lung. The pleural space is the space between the membranes that envelop the lung and the membrane that lines the inside of the chest. The membranes are referred to as the pleura. The membrane covering the lung is referred to as the visceral pleura, and the membrane lining the chest is referred to as the parietal pleura. There is normally no space between the visceral and parietal pleura, and they slide smoothly over each other, lubricated by a light fluid. There is a constant negative pressure within the chest, maintaining the expansion of the lungs. If there's damage to the pleura, air or blood may enter that space between the visceral and parietal pleura and cause the lung to deflate or collapse. Elastin, a component in the composition of lung tissue, has a property rather like that of a rubber band. When elastin is stretched, its natural tendency is to recoil. When the lungs are properly inflated, this tendency to recoil pulls constantly against the lung, trying to cause them to collapse down to, which they can do if air enters the chest. They may fall down to 5% of their normal size. The constant inward pressure helps maintain the negative pressure that keeps the lung inflated. Here's a drawing of the lungs inflated. The visceral pleura is lining the lung. The parietal pleura is lining the chest. Sometimes when we run, we get a sharp pain in our side that makes it difficult to breathe. This is pleuritic pain. We refer to it as stitch when we're running, and it passes normally on its own. Patients with pleurisy experience that pain on an ongoing basis because the pleura is inflamed. When the diaphragm contracts, it becomes flatter, pulling the lungs down, creating a negative space inside the chest, and drawing in air from the outside. The minute ventilation refers to the amount of air moved in and out of the lungs in 1 minute. The minute ventilation is said to be comprised of the tidal volume, or the amount of air that moves in and out with each breath, times the frequency of breaths. Changes in tidal volume or frequency can alter the minute ventilation, possibly detrimentally. A decrease in minute ventilation will decrease the amount of air available for gas exchange and can lead to cellular hypoxia. Alveolar ventilation refers to the amount of air moved in and out of the alveoli in 1 minute. It takes into account the dead space, or the amount of air, the space occupied by air at the beginning of the ventilation of a breath. When the patient inhales, the air that is already in the airways moves into the alveoli, and when the patient exhales, that air moves to the outside. As long as the minute ventilation exceeds the volume of the dead space, a sufficient air exchange will occur. But if the patient's breaths are so shallow that the dead space is not completely evacuated, then the alveoli will suffer from poor ventilation. We calculate the alveolar ventilation by deducting the dead space from the tidal volume. In the average adult patient, the alveolar ventilation can be calculated by subtracting the dead space of about 150 milliliters from the 500 milliliters of a normal breath, yielding 350 milliliters of alveolar ventilation. For example, a patient has increased their ventilatory rate to 28 per minute to compensate for a decreased tidal volume due to pneumonia. By doing so, their minute volume returns almost to normal. But they may still display signs and symptoms of hypoxia due to poor alveolar ventilation. Simply because a patient is breathing, even at a rapid rate, does not mean that they are breathing adequately to perfuse the lungs. We have to consider how much of the breathing is taken up by the dead space in the tidal volume. Again, though the patient may breathe faster to improve his minute ventilation, the amount of air available for gas exchange in the alveoli may be insufficient if the tidal volume is low. The dead space will fill first, regardless of the amount of air breathed in. And if insufficient air is breathed in to clear the dead space, alveolar ventilation will suffer. If we have a patient with inadequate tidal volume, we need to provide positive pressure ventilation to increase the tidal volume and move more air into the alveoli. When we place a oxygen mask over a patient's face, we enrich the air in the dead space, but if the patient's ventilations are too shallow, little oxygen will reach the alveoli. In summary, the airway is the channel of life. With no airway, the patient cannot survive. Adequate oxygen levels in the inspired air and good ventilatory effort are integral to assuring adequate oxygen levels for cellular metabolism.